COPD, as Mr. Rule has said, this is COPD Awareness Month. Again, a reminder that 24 million Americans have COPD. Half of them do not know it. Early diagnosis requires testing with spirometry. Cough, phlegm, shortness of breath, and wheezing are the most common symptoms. And COPD can progress rapidly, particularly if you smoke over a number of years, or it can progress slowly. Also, the rapid progression can come because of acceleration. In other words, it is typical of many illnesses that for many years it slowly gets worse, and then it sort of picks up, and then you're sort of going downhill very quickly. And that progression is often signaled by hospitalizations. So there's no question that it can progress, but there's also no question that it can progress very slowly, hopefully over 100 years. And many of us will not be bothered by it. So, again, I would like to talk about smoking cessation. 20 to 30% of persons with COPD still smoke, oftentimes surreptitiously. They know it's bad for them. They certainly have everyone around them reminding them of that. And it's very difficult to sometimes figure that out. It's very sad, of course, when I have a patient in my office with severe lung disease who tells me they don't smoke, and yet they reek of tobacco smoke. It's very sad because they're really deceiving themselves, not me. But I think that we can never forget that this is still a major problem. One of the talks I gave a long time ago, seems like a long time ago, several years ago, was about screening, lung cancer screening. And that's one of the things I'd like to mention later on. But certainly if tobacco smoked is stopped, even for, if you can lower those percentages from 20 to 30% to 10, we practically eliminate 50% of the lung cancer in this country. So it's a very difficult procedure, it's a very simple procedure, but it's still worthwhile to consider. Cigarette smoking is considered a chronic disease, therefore it's treated like a chronic disease, very much like you treat COPD itself, or treat diabetes, or treat high blood pressure. In other words, very often you just can't do it at once. It has to be done over a period of time. There are many exacerbations or failures, but above all, the idea is keep at it, keep going, keep moving. I think that there is a combination best of counseling and medications. The idea is to use controller medications, and then to, if there's an urge, to use another medication. So basically at least 2 medications are used. One of them, for example, is an antidepressant, or varenicline, which is Chantix, and then on top of that use something when you have an urge, something like a lozenge, a nicotine lozenge. I think the quit date is very important. I emphasize this to my patients. In other words, you have to set a date where you do something different, exciting, hopefully with your grandchildren, and on top of a mountain with no cigarettes around. And I think you have to commit yourself to that. E-cigarettes are controversial. I think that studies have come out pro and con. While on the surface, e-cigarettes are, quote, better than cigarettes because they don't contain as many carcinogens, the problem is we don't know what they contain. We know they contain nicotine, but the companies have been able to not classify it as a drug, and therefore they don't have to divulge its contents. So we know that they are spreading like wildfire, particularly among the youth of our country, and it's not clear what's going to happen over the next few years. But it is selling, it is making the companies a lot of money, and so the regulation is going to proceed very slowly. But at least we have to figure out what they contain, and this varies from company to company. And some of my patients use them. They tell me I stopped smoking cigarettes, and I'm smoking e-cigarettes. I'm not sure if it's better, but we'll have to wait and see. The next area I want to cover is exercise or activity. I want to remind you that as little as 5 minutes a day of exercise makes a difference. All of us do more than that, but the maintenance of fitness requires at least, let's say, walking 3 days a week for 30 minutes. Again, that's not much, but it's amazing how many people don't do that. If you want to increase your fitness, then we have to go to about 30 to 60 minutes, about 5 days a week. And again, many of us fit that bill, some of us don't. We forget that you're either gaining muscle or you're losing muscle. There's no such thing as you're about the same. You're either gaining or you're losing. So if you're not active, you will lose muscle. And certainly, once you lose muscle, that's one of the main reasons to be short of breath. So I think that exercise is the best predictor of mortality in both heart and lung disease. And it's functional. Certainly exercise, by the way, is also the best predictor of, for example, complications with surgery. And I think that that is perhaps surprising in this day and age with all our technical equipment and all our testing and all our, CT scans, that if you ask a patient, what do you do during the day, that is the best predictor of how they're going to do tomorrow, the best predictor of how they're going to do in surgery, the best predictor of whether they're going to be alive or dead next year. And again, modern medicine confirms all the time, and there's always a study every 5 years, exercise, yes, is the best predictor and better than any medicine. Next, pulmonary rehab. Again, I always think of Mr. Jones because he and I were always pushing exercise and pulmonary rehab. Again, it's a program. We have them at the hospital. They always tell me I'm the one who refers the most patients. But it does help to reduce shortness of breath, helps reduce depression, helps reduce hospitalizations, helps reduce exacerbations. It increases activity, oxygen saturation, sense of well-being. One thing it does not do is improve your pulmonary function test, which is always surprising to patients, but who cares? If you can do more, that's where the money is. And it also increases endurance. And the sad part is still true that only 25% of patients with COPD ever go to pulmonary rehab. And that's a problem. It's also a problem because if you smoke, then the government will not pay for it. One of patients here, Mr. Raymond, where are you, sir? Yeah. Mr. Raymond asked me, I asked his permission. Mr. Raymond, when I do the breathing test, he's terrible. In fact, worse than most of you here, but he does exercise and he's very fit. And part of that is the fact that he's never stopped doing exercise, and part of that is the fact that he's still thinner than I am. But I think it speaks to the fact of how important exercise can be. And if you keep going, you keep going, and that's very important. Let me talk about, very briefly about medications. I think there are basically three main issues with medicines, and I don't have the time now to go over in detail many of them. In prior lectures, I devoted the whole talk to talking about medicines. I think what you have to know is, number one, how long do they last? Whether they're short-acting or long-acting. In other words, is the medication you're taking, the inhaler or the pill, does it last 4 hours, does it last 12 hours, does it last 24 hours? And that's very important. So you have to know that. You have to know how long your medications last. There are short-acting medications, and these were the only ones available 20, 30 years ago. However, now we have medications that last 12 hours and 24 hours, so-called the long-acting medications. The long-acting medications now are considered the best drugs for COPD. And I would agree with that, because most of us don't take medications 4 times a day. Most of us forget. So if you take a medication that can last 12 hours or last 24 hours, you're way ahead of the game. Number one, because at least you can be more active. You can leave the house and not think about going to the bathroom or going somewhere and taking an inhaler. And number two is, if you happen to be exposed to a cold or an infection or an allergy, these things immediately tend to affect your airways, make you short of breath, increase phlegm, increase sputum, and the idea is if you have medications on board, they hold. So therefore, they hold those airways open. You can get rid of the infection that much sooner. You can not allow the allergy to affect you. So medications serve many purposes. And I think that we forget that the purpose of medications is to prevent the problem as well as to control the problem. I'm all for prevention. We were told that an ounce of prevention is worth a pound of cure. That's very, very real for medicines. And I'm forever emphasizing, take your medications, but doctor, I feel well. Well, yes, but you take them so you don't feel bad tomorrow. And I think that the use of medications in those circumstances is a very good one. There are also nebulizers. In other words, nebulizers, you put a medication in a device, and I'll try to show you that in a minute. And then there are steroids. Steroids, we know now, are probably overused in COPD. Steroids is the first line of treatment in someone with asthma, but not in COPD. And I'm impressed how many of my patients look at the internet, which is good. You should be well informed. But the point is that there is such a thing as triple therapy, which was pushed many years ago with not very much information. It's quite expensive, and it means that you have to have 3 medications for COPD. I'm not sure how that became very popular, but one of them is a steroid, and probably most of the times it's not necessary. All right. Let me go to inhaler techniques. And this is very important. I devote a great deal of time to this. And the oldest device is called a metered dose inhaler, and most of you know how to use it, but I'll tell you how I explain how to use it. Why am I doing this? Well, because 70 to 80% of the time, you don't do it correctly. I repeat, 70 to 80% of the time, people do not do it correctly. That's awfully high. To use an expensive medication for a serious illness, that probably is not going to work. So we have a problem there. And partly is our problem, partly is your problem. We now have the internet and YouTube, and I always tell my patients to look it up. There's always someone young, beautiful, who clearly doesn't have COPD, but who will teach you how to use it. So I think the point is, I always say there are several important things. First of all, make sure you prime it, which means it should come out. I'm not sure if you remember, these things got more expensive lately in the last few years, and the propellant was changed. The propellant, or the gas, is the substance on which carries the medicine, the actual medicine, and that propellant is more sticky now, so therefore these things get stuck more. And if you haven't used this for more than a week, they have to be primed. So after you prime it, make sure it comes out. You can do it once, twice, or 3 times. By the way, that's mostly the gas. There's no medicine here. Then you're ready to go. And I always tell people, this is a musket, not a machine gun. You can't go bang, bang, bang. That doesn't work. You have to go bang and wait 2 minutes. And then go bang and wait 2 minutes. You have to wait. It has to reload, so to speak. So you primed it, and you waited your 2 minutes. You shake it, air out of the lungs. I always sort of say, look down, put it in your mouth, start breathing, and then hit it. And then breathe, breathe, breathe all the way in, and hold it in for 10 seconds, and count 1, and 2, and 3, and 4. People say, I'll be dead by the time I get to 10. But the idea is to hold it in, because you want that stuff to settle down, and then exhale slowly. The usual dose is 2. puff. So you wait 2 minutes, do it again. Can you wait 1 minute? Sure, that's fine. But that's the idea, and you have to go through that in your mind, exercise over and over again. Now, what really helps, of course, is a spacer or a chamber. And many of my patients do that, but I'll tell you one thing, nobody carries a chamber or a spacer in their pocket, just about. So if you have a chamber or a spacer, that's fine, it makes it much easier. Basically, if you put a chamber on here, what a chamber is that it holds the medicine, and then you can take it in. So if you have a chamber or a spacer, you put the medicine in there, you let it settle down, and then you take it in. Now remember, these inhalers, the medicine comes out very fast for a very short time. I say 60 to 70 miles an hour. I'm not sure that's true, but they come out very fast. And it's 0.3 seconds. So it's actually less than 1 second. So that's what you have to grab and take in. That's very difficult. But if you put it in the spacer, what you have is a spacer. Now you have to put the spacer here over your mouth, keep your mouth shut, put the medicine in there, let the medicine sort of settle down, and then open your mouth and take it in. That's the idea of a spacer. And then you wait, again, 1 or 2 minutes. Again, put this in there, keep your mouth shut, hit, let the medicine settle, open your mouth, take it in. That's the idea. Again, that's a lot, but again, if you go to YouTube, you'll get it going. Now, the problem with this, of course, if you wait till you're sick, you have an infection, you have an allergy, you're short of breath, well, that's the time you're not going to do it right because you're stressed. So it's best to practice as best as you can. Now, because everyone recognized that there was a problem with these inhalers, along came what's called dry powdered inhalers. Those are metered dose inhalers. Those are MDIs. These are dry powdered inhalers, DPAs. The dry powdered inhalers, of which this is one of them, this is called a discus. The fact is that there's a powder, and you basically inhale or suck in the powder. It doesn't come at you. You have to grab it and take it in. So therefore, the thinking was that there was a better chance for you to actually get the medicine. So under these circumstances, I always say you hold it like a hamburger, you open it up, whoops, I have it upside down, sorry, and you pull the chamber back, and then you go, again, over 10 seconds, you hold it down, and generally these is only 1 puff. You have to know whether it's 1 or 2 puffs. This is generally 1 puff. By the way, there's nothing sacred about the inhaler taking in 2 puffs. I have patients who tell me, I take 2 puffs and I'm jittery and I have palpitations, I get anxious. I say, take 1 puff, not 2. Nothing wrong with taking just 1 puff. There are other types of dry powdered inhalers. I won't go through all of them. There are modern delivery devices, which all of you have probably, or most of you have come to rely on. The modern delivery devices try to take the disadvantages of this and make it better. So the modern delivery devices, they slow down the medicine coming out. So you sort of look at it almost like a mist, and they do it for a longer period of time. Now that longer period of time, instead of 0.3 seconds, is 1 whole second. So slower velocity and longer time, allowing the patient to take it in more. They're certainly an improvement. They're also much more expensive. There's a third device, and that is the so-called nebulizer. And the nebulizer is something, if you go to the hospital, this is what they're going to use for you. Why is that? Well, because the nebulizer, you sit there and you smoke this for a couple of minutes. And therefore, some of the medication is going to get down. So instead of 0.3 seconds, you've got 3 minutes or 2 minutes to take the medicine in. And you're bound to have some of the medicine go down into the lungs. So that's the idea. This is called a compressor. This is the tubing, and you have this, and you put the medicine in here, as most of you know. Now, generally, what you put in here is a vial, something like this. You take it, you break the neck. Again, nothing sacred about putting the whole vial. I tell patients if you have side effects, use half a vial, use a third of the vial, use a fourth of the vial. I mean, whatever it takes or doesn't take to get an effect. Some people obviously are more susceptible to side effects than others. So the medicine does work. Nothing, again, if you half a vial works, that's fine. I wouldn't, however, if you only use half, save the other half, because that's an easy way to get contaminated, so I would just throw it away. But anyway, I think that that's something that could be done. Again, I emphasize the technique of this, and this tubing, by the way, has to be changed about once a month or every 2 weeks. There's moisture coming through here, and this is going to get fungus. Every 1 or 2 years, I get a patient who has terrible fungus allergy, and they tell me this thing, they haven't changed it in a year. So those are kind of small details that we forget about, but they make a big difference. So again, I think if you have these devices, if you use them, devote a lot of time to knowing how to use them, and once a month, recheck yourself to make sure that you indeed know how to use them. All right, I spent a lot of time with this, but I'm always impressed that when people don't get it right. As you know, mini dry powdered inhalers, rather than this, they come in pills, which you have to break up. You put it in the device and you break it up. For example, Spiriva is that way, so is Floridil. And of course, when they first came out, patients didn't break them up, patients swallowed them. But I think that that's another way to get the proper medication. All right, let me move on here in the interest of time. I can always come back. All right, question. Let's see how if you're awake. A 70-year-old patient has severe COPD with some heart disease, and he has been a heavy smoker, and he continues to smoke. What will he die from? COPD, heart disease, or lung cancer?
All of the above.
All of the above. But if you had to pick one, which would it be?
Heart.
If you had to pick two, what would it be? Okay, if you continue to smoke, you'll probably die of heart disease, but also lung cancer is number 2, other cancers are number 3, and respiratory is 10%. Again, this is important because I want to stress the importance of, 1, stopping to smoke, and number 2, the fact that if you continue to smoke, you're going to die of other things. Not so much of lung disease. You're going to die of heart disease, and you're going to die of cancer, and there are other cancers. You know, cigarette smoke is involved in just about any cancer you can imagine, including breast cancer, including stomach cancer, many, many things. So I think this is important because somehow the impression that's made is if you have bad COPD and you smoke, you're going to die from lung disease. You're probably going to die of other things first. By the way, if you, in the general population, of which, again, 20 to 30% of people smoke, respiratory and heart are still very high. Cancer is still high, but probably respiratory will be number 1. If you stop smoking altogether and years go by, then respiratory becomes number 1. Okay, lung cancer screening. Lung cancer screening has been approved by Medicare, and it's also mandated by Obamacare, so private insurances also have to cover it. That's the good news. The bad news is that it hasn't been implemented, and that we're still awaiting the guidelines and the rules and regulations under which it can be implemented. So here we are. So any day now you'll be able to go out and get lung cancer screening, but not yet. In general, lung cancer screening is for people ages 55 to 75. What about if you're older than 75? Well, that's a problem. Why were those age restrictions put in? Well, because that's the age group that gets cancer, lung cancer, and number 2 is a major requirement is that someone can do something about the cancer. Either you can have surgery, chemotherapy, or radiation, particularly surgery. Lung cancer screening, the idea is to find cancer at an early stage. Right now, when we find lung cancer, 75% of the time it's spread. So 75% of the time, you basically cannot do surgery. You have to do radiation or chemotherapy, which in effect is palliative. Most of the times it's not curative. What you're trying to do is beat a slow, dignified retreat. You're not advancing. But I think that the 75 age group probably will let go. I mean, the general rule of thumb for lung cancer as in prostate cancer is that if you're going to live 10 more years, by all means do the most you can. If you're going to live 1 year, then you may not want to do very much because the stress and the grief and the suffering from the therapy may not be worth it. No symptoms. Obviously, people with COPD do have symptoms. They're short of breath. But the idea here is that screening means that you don't have disease. Screening means that if you did have disease or if you did have an abnormal chest x-ray, that's not screening. That is case finding. That if you have an abnormality, then Medicare will certainly pay for the CT. So you have to keep that in mind because there's a misunderstanding here. I see patients refer to me for lung nodules that they paid for the screening, and the first thing I do is look up the old x-rays, look up the old CTs. Has that darn thing been there 20 years? Oftentimes it does, so why did the patient pay for something that's been there 20 years? So you have to be careful, you have to be reasonable about this, and if you've had x-rays or CT many years ago, that's the first thing you'll look up. And if you had something, for example, many patients have already been followed. If you find a nodule on chest x-ray or CT, and it's a small one, I don't want to get into too many details, but the point is that you follow it over 2 years. If it's stable over 2 years, then it's a scar. Cancers grow. If it doesn't grow, then it's probably not a cancer. And many of my patients have already been through that 5 years ago. So there's no point in going through it again. Again, the point is that you can withstand lung cancer treatment, particularly surgery. Medicare has mandated, which I think is a good idea, something called shared decision-making counseling session. In other words, they at least have indicated that there has to be at least a session where the patient and the doctor go through this in great detail. Keep in mind that even in a smoker, someone who's smoked 30-pack years and is, let's say, age 65, if we find a nodule, 95% are benign. So there's a small chance that it is malignant, quite a small chance. And you're talking about another CTs for at least 2 years, or even taking it out. So it's there's a great amount of detail and reasoning that has to go through this. Okay, vaccinations. Again, all of you, I'm sure, got already your influenza vaccine. I got mine last week. I'm still here. The confusing part comes with pneumococcal vaccines. It's technically pneumococcal, it's not pneumonia. Pneumococcal vaccines prevent about half of all pneumonias, not 100%, only about 50%. And there are two of them. There used to be Pneumovax, which is the PPSV23, and that was given, Medicare pays for once before age 65 and once after age 65. We'll put aside things like cancer, immunosuppression, and so forth, which is every 5 years. There's a new one called Prevnar 13, which is PCV 13, and that's recommended to be given once after age 65. The problem, I think, which is about resolved, again, is that Medicare will only pay for one pneumococcal vaccine after 65. So if you have one, it won't pay for the other. That's a little, but the CDC, some federal agencies recommend it, but Medicare is not paying for it. So we're in a bind, but I think that also will be resolved because I think that it is a very good vaccine. The other point to keep in mind is that they should not be given together but about a year apart. So if you get a vaccine, you have to wait about a year to get the other one. But I think it's useful, definitely useful to have both. Okay, overlap syndromes. I think this is a whole area to me which is very important, because by overlap syndrome I mean the COPD has something else, and that something else has to be treated correctly, otherwise the COPD is not going to get better, and it leads to more and more exacerbations. And oftentimes that other entity is not treated well, is not followed well. Or the patient tends to focus on the COPD and not focus on the other entity. First of all, the biggest one of them all is COPD and heart disease. Again, I've already mentioned to you that without doubt cigarette smoking, the greatest damage of cigarette smoking is not to the lung, although I'd like to think I'm important and say it is, it's really to the heart. That is by far the greatest damage. And I think that if the day you stop smoking, also your heart disease gets much better, but it's still a major factor. I find this is confusing. Shortness of breath can either be heart or lung. Sometimes it's both, sometimes it's one more than the other, and it's very difficult to sort this out. But the point is that the heart disease has to be treated. There's also COPD and asthma. Some people have asthma when they were children, they smoked, and now they have both. The important point to keep in mind here is that asthma is 80% caused by allergy. Therefore, to treat asthma, that's a different topic altogether. Many of the medications are the same, like the inhalers, but there's also allergy testing in asthma. There's allergy treatment. There are a few other medications that are used in asthma that are not used in COPD. And in fact, the rule of thumb is if someone has asthma and COPD, you treat them as if they had asthma, because you have more options available to you. We forget that. And of course, the first rule of thumb with asthma or allergy is avoid the allergy, which, since we're in the mold capital of the world, is difficult if you have allergic to mold. COPD and bronchiectasis. Bronchiectasis means the airways are damaged, and invariably you have infections. And those infections will keep coming back generally. The prototype of bronchiectasis is cystic fibrosis. But the point is that cigarette smoke can damage the airways, and then it becomes, unfortunately, a difficult situation because you always have phlegm, you always have sputum, and you have to treat infections constantly. It's a different approach to the illness. Next is COPD and sinusitis, and this is one of the things that I have to emphasize constantly. If you don't, the nose is the key to the lungs, and if you don't treat the nose in terms of allergy or sinusitis, you will get more infections. Certainly I have a lot of asthmatics that come to me, and invariably the main reason why their asthma keeps coming back is because their sinuses are not well treated. The problem with the sinuses, of course, is we take them for granted and we ignore them. Now, having myself allergies and sinusitis in the past, I take care of them. And I always tell patients, generally have to use 2 or 3 medications every day. Every day I use saline wash, I use an antihistamine, and I use a nasal steroid. I've done that when I was young, even in medical school, I always had sinus infections, but the last 25 years I haven't, and that's because I use the medications every day. Every day, every day, every day. 3 medications. And I think that takes care of that problem. If on top of that you have COPD, then forever you're having problems. So I think we de-emphasize something that's the key to the lungs. COPD and sleep apnea. Well, this is self-serving. I am a sleep expert. But certainly if you have sleep apnea that's not treated, your lungs will get worse. There's no question about that. So oftentimes, for example, I myself have missed for many years that the patient tells me they're short of breath, I think it's their COPD or their heart disease. Then all of a sudden their spouse shows up and says, you know that, he snores. We do a sleep study, we treat him, all of a sudden their shortness of breath gets much better. I sort of tell myself, God, how did I miss that all these years? But that happens. COPD, depression, and anxiety. Again, tribute to Mr. Jones, he always emphasized this. You can panic. You can panic if you get short of breath. There's no question about it. The problem is when you panic, you tend to breathe more. And if you breathe more, now you're more short of breath. And now you panic more. So it's a vicious cycle. There has to be a way of calming down. There has to be a way of not putting an extra stress on the lung because the lungs cannot handle that extra stress. So this is a very important area where exercise, where companionship, where coaching, where mentoring is very important. I don't know how many patients I see at the hospital that they have a panic attack. That's the reason they went to the hospital. And of course, our healthcare system being what it is, you can't put down anxiety. Medicare won't pay for that. No insurance will pay for that. So, and unfortunately, it becomes a major problem. Now, a patient who panics and who can't breathe is clearly in trouble. I mean, that's a patient who can really get themselves into serious difficulty, even put themselves on a ventilator. So it has to be controlled, but again, one of the keys to the lungs is your attitude, your ability to deal with these problems. COPD and lung cancer, I've already spoken about that. If you smoke, chances are you'll die of lung cancer, not of COPD. And let me leave it at that. COPD, bone and muscle disease. I want to say 2 points here. Remind you that COPD medications, particularly the inhalers, make you less short of breath and make you more active. So they don't cure COPD, and they really, in a sense, COPD progresses despite these medications. Although they do help prevent infections, they do help increase exercise, they do help keeping you out of the hospital. But the point I'm trying to make, and oftentimes happens, is that if my patient has bad COPD and on top of that they get a stroke, and now they can't get around very well, stop the medications, decrease them. What's the use of them? And I think that very often that's a time when you have to go down on medicines, not up. And to maintain a patient on so-called triple therapy who cannot get around very well is a waste of time and money. I always say, if the medicine is not helping you, then it's hurting you. There is no perfect medicine that I'm aware of. They all have side effects. And therefore, if it's not helping, stop it. I see no point to that. Number one. Number two is that clearly there's a relationship with COPD in terms of osteoporosis, in terms of, and arthritis can worsen. So there is a sense here that in terms of mobility, I would say that a good percentage of my patients with COPD, it's not that they can't get around, it's not the shortness of breath, it's that the bones, their back, their legs, that's really what keeps them from being mobile. And so it's something that has to be paid attention to. Next, community care of COPD. There is self-care, there's family care, there's community care. And probably this is the best form of care. I think this is immensely important in treating anxiety, depression, especially secondary to isolation, lack of interaction, spiritual poverty, lack of exercise. As a medical student, I learned very early there was such a thing as psychic pain. Psychic pain is a patient who is dying and fears death and very clearly doesn't know what they're dying. In fact, they never knew when they were living. I have no medicine for that. And oftentimes that's clearly the most debilitating problem that they have. And the medical profession is not going to solve that problem. The community is, their family is. They themselves have to solve that problem. And I think that's where I think spiritual meditation helps. You don't have to be religious. I am, but I think there has to be a reason why you're living and why you're dying. And there's also advocacy at the government level, insurance level, hospital level, organization, COPD Foundation. I think that these are the best of times in the sense that you're continuing to interact, continuing to grow. There's no question, however, that there is, like exercise, if you're not gaining, you're losing. I think unless there's a movement forward, the government will take money out of COPD and put it somewhere else. There's a great demand for money here. COPD, unfortunately, has never been the poster child of obtaining funds, either from the public or the government, but that can even get worse in the future. So if you're not writing letters to your congressman, the president, local, then we're sure to lose. There's no question about that. But I think that the idea is that we can keep on winning if we keep doing it together. Okay, website and references. I just wanted to list those. You probably have all these. I want to go to a final topic before I open this up for questions, that is stem cell clinics and the idea of placebo. Many of my patients are doing stem cells, and at best, stem cells treatment is a for-profit experimental procedure. I repeat, it's a for-profit experimental procedure. At worst, it's a fraud. I think that experimental procedures in medicine, I mean, that's the way medicine advances, right? You think of something, you say, is there a biology behind it? Can we test it in animals? Can we test it in humans? Does it work? That's how all our medicines were developed. So there's nothing wrong with that. However, once you make it for profit, that's unusual. In all my years in medicine, I've never seen an experimental procedure that you had to pay for. Because if it's experimental, it means that it can do harm, it can do good, or it can do nothing. As a rule of thumb, and again, this is my own perception over the years because I've seen many therapies come and go, there are many books written on the subject, is that new therapies, before they're actually tested, before they're actually used, about a third of those therapies help. That's the good part. That's what we want. But a third of the time they do nothing, so therefore there's no point in taking a therapy that does nothing, but they have side effects. But a third of the time they hurt. And clearly there are many therapies that we sort of wish we'd never done because we actually hurt the patients. In my own practice, I've had many patients who participated in clinical trials with the best of intentions, but they actually were worse off at the end than in the beginning. That's not to say that it was not worthwhile to do that. That's not to say that they wouldn't do it again. But the point is that we don't know if these things help. If you turn to the last page of my handout, this comes from stem cell treatments, 6 false hope warning signs. This actually, there's an organization called the International Society for Stem Cell Research. I actually have some of these handouts if you're interested. I have less of them. This is the international organization on what's called regenerative medicine. There are experiments all over the world. Many people are very hopeful that we can get very good treatments out of this, and there is, I can devote more time later on to try to explain to you why. But this is a handbook, and out of this handbook, I think these were very perceptive scientists and physicians and lay people like yourself, and they put out these 6 what they call false hope warning signs. One is claims based on patient testimonials. What that means is that people have come forth and said, this works for me. And I've gone through the internet, and I have no question about the integrity, and I have no question that patients, many people say this works, it worked for me, and I paid for it, I'm glad I paid for it, period. Number 2, the same stem cells are used to treat multiple diseases. I've listed some articles here. Stem cells can either come from blood, or the 2 favorite sites are blood or fat. They can be injected back. Generally, of course, if you treat the lungs, then you want to have a stem cell from the lung, not a stem cell from the blood, for example. And by the way, we've done stem cell transplantations for leukemia for many years now, 30 or 40 years. So it clearly works there. Next, the source of the stem cells is not clearly documented. Next, how the treatment will be done is not clearly documented in a protocol that serves as the medical practitioner's operating manual for the procedure. Well, what that is saying, there has to be a scientific way of doing this, and it has to be spelled out. Claims there is no risk. All medical procedures carry some risk, and all stem cell treatments, either at the time or before that, you have to have, you sign. And there's a lot of disclaimers, clearly can do harm, including death. So no one's going to give you a treatment unless you sign that. And next, the high cost of the hidden cost. There are legitimate clinical trials that don't charge patients. There's a trial in Miami going on now for pulmonary fibrosis, for example, with stem cells. There was another trial that treated COPD that was not successful. There's a trial in Boston that I think is very hopeful because they like to target cystic fibrosis and alpha-1 antitrypsin deficiency. The reason for that is because we know the exact problem in those diseases. So the idea is you can fix it in the stem. You have to take the stem cell, fix that, and give it back to the patient. And that, at least maybe 20 years ago, was kind of almost like unknown science. Today, that's very doable. It's being done in mice and in rats. But there's a lot of engineering. There's a lot of work that has to be done. We're about 5 or 10 years away, but hopefully not 20 years. So that's where we stand. I think that what I'm trying to do is give you some clarity. I've listed some websites that I think speak to the issue. And finally, the topic I want to discuss is the so-called placebo effect. Placebo is, to me as a medical student, I was fascinated by it. The placebo effect was first written about with pain. In other words, if I have, let's say, 100 people that were in an accident, they had crush injuries to the hand or the leg, I mean, this is real pain. And as a physician, let's say I go around with my medication. Let's say I don't give them morphine, I give them sugar water. And I have a nurse with me, we're both very professional, we're well dressed. The patient believes that we are clinicians, they believe in the medicine we're giving me. How many of those patients will have their pain completely resolved? I mean, if I give sugar water to patients that have real pain, how many of them will tell me their pain will be gone? Huh? Anywhere from 30 to 60 to 70%.
Really?
30 to 70%. In every war, and my cousin was fought in Iraq, he was a medic, they ran out of morphine. They didn't have enough morphine to treat the soldiers who were shot. They gave them saline. You don't do nothing, you give them something. And yet so many of the soldiers experience relief. So, which goes to show you that, and we know now, and there's been a lot of research in placebo, as you know, I'm fascinated by this. I gave some websites if you want to read about it. We know instinctively that if someone is in distress and someone is in pain, I'm the doctor, and I give them morphine, and if you come later on, and it's your good friend, your son, your daughter, and you console them, and you hug them, you probably will relieve their pain almost as much as I will. I think we all have a sense that that is true, because both my medicine and your consoling work through the same areas of the brain. In other words, the medicines, all pain is in the brain eventually, and all pain is relieved by the brain eventually. And there have been some startling, for example, some of these websites show you can actually picture the brain, and we know that this area has to do with hand pain, and we know that if we give morphine, this area lights up, and this area is better. But darn it, if you come along and console the patient and they believe in you, that also lights up. And somehow you're as good as relieving pain as I am. So eventually, it comes down to whether you believe in it or not. It comes down to whether that part of the brain can respond. And there's some incredible things. For example, Parkinson's disease. Parkinson's disease, we know, is a lack of dopamine. We give people drugs that are basically give them dopamine, and you can show that the Parkinson patient in this part of the brain has less dopamine. You give them the drug and the dopamine goes up, almost to normal. Not quite, but almost. And yet, if you give them sugar water, guess what happens? Their dopamine goes up. And we don't understand that. I mean, why did they get it now and not have it before? So there's a lot about the brain and our ability to heal ourselves that we're just barely understanding. So the placebo effect, as one of these articles put it, it's not a dirty effect. It's simply the fact that we're so good at, and think about it, I don't know, my grandmother had 7 children at home, my other grandmother had 7 children at home. They all survived, and she survived without any pain medications or anesthesia either, as I'm sure many of your grandmothers did. How can that happen? And so many throughout history, we didn't have any of these medications to deal with, but we survived. And I think that the other interesting fact about the placebo effect is that many people are saying that over the last generation in America, the placebo effect has actually grown. Many years ago, for example, when antidepressives were tested, drugs against depression, there were several trials that, well, let me back up. The FDA requires, if you come up with this miracle drug that's going to treat depression and you want to sell it, the FDA will say, wait a minute, you've got to do a trial that includes placebo. So you've got to give this drug to 100 patients, and to the other 100 patients, give them the exact pill. Don't tell them they're not getting the drug, and don't tell them what they're getting. And then at the end, see what percentage of patients in this group that got the drug got better, and what percentage of patients in the placebo group got better. In several trials of major antidepressants, the answer was the same percentage got better, 60%. And they couldn't believe that. Of course, drug companies don't spend millions of dollars to get negative results. So my understanding, there were 5 trials. 3 said there was no better. 2 said yes, the FDA approved it. Instead of one was 60%, the other one was 65 or 70%. And they said, fine, that's good enough. We'll take it. And I must say, in some of the testimonials that I read about patients who were very angry because they said, listen, I want my stem cells. Why the heck does the FDA have to stop that? It's my money. I'll do with it what I want. And they said, listen, what are you talking about? Doctors give pills all the time. There are studies that some doctors do use placebos, and they know that it works. So many doctors have given pills for this, that, and the other. The patient gets better, they don't argue with it. So I think it's a problem. I think it's a fascinating area of medicine. But I think, if anything, it sort of harkens back to the point that our bodies, our attitude, our family, our friends, our community, is still an incredibly good healing process. And we shouldn't lose sight of that. And I think that I am, my wife says that I will be the worst patient in the world, although I'm pretty healthy now. I don't like medicines and I don't like doctors. I think that the point is, and I do believe strongly in exercise. I do believe strongly that most of the times I can heal myself. I do believe strongly in other areas, certainly the power of spiritual meditation. So I like to think that stem cell therapies have done a good thing. They've challenged us. They've challenged me as a doctor, and they've challenged the profession, they challenged the system. Come up with something, because what you're doing isn't happening. And I think that's a good challenge. And I think that On the other hand, I hope that I've shown you that be careful about these therapies, particularly because I'm concerned that they can do harm. And I thank you for your attention. Questions, comments?
On the nebulizer, you
Yeah.
say that you changed the tubes. I have 2 tubes. Do you have to get new ones, or you clean the ones that you have?
Yes, in other words, what I do when I prescribe, for example, I prescribe a compressor, and I prescribe these tubes on a monthly basis. So I say, give the patient a month, every month, change the tubing. And
Okay,
they'll
I
be-
have a nebulizer, but I don't have, I got it when I was in Michigan. I don't have a prescription to change the tubes.
It should be changed, yes. Okay.
Thank you.
Yes, sir. Okay, so the question was, when do you, do you have to change the tubing? And the answer is yes, and that requires a doctor's prescription, and we oftentimes forget. I find that by the way, this is a nebulizer unit. This is why I was trying to, and this is the tubing, and this is the compressor. And the medicine is nebulized, meaning you put a liquid in here, and the air is forced in, and the air makes a mist out of it. That's the nebulizer unit. There are other nebulizer units, but this is one of them. You have to change the tubing. They should be changed at least on a monthly basis. If you use it 4 or 5 times a day, which some of my patients do, then it should be changed every 2 weeks. But there's moisture going through here. There's no way you're going to clean this. So it will grow mold.
Thank you.
All right, thank you very much. I appreciate your attention.
Thank you, Doctor.
Thank you, Doctor.